Basics of biliary stents for obstructive jaundice. On the 1st of November, a patient seen in OPD for obstructive jaundice is diagnosed with a resectable periampullary mass. He has an obstructive jaundice history of 3 weeks duration. On the 1st of November, his total bilirubin is 8, direct is 6. Rest of the lab parameters are all normal. He's counseled about a Whipple's procedure, wants time to decide, arrange logistics, and comes back after 15 days. On the 16th of November, before his surgery, lab parameters repeated. Bilirubin, as expected, has risen from 8 to 16. Indirect bilirubin has elevated from 2 to 4. There's a mild leukocytosis without a history of fever. Urea is elevated. Liver enzymes are slightly elevated. Albumin has dropped from 3.6 to 2.6. INR has risen from 1.1 to 2.1. So, what has happened? Why did indirect bilirubin rise in a case of obstructive jaundice? What is the significance of elevated urea and creatinine? Can liver enzymes rise in obstructive jaundice? What is the significance of this elevated liver enzymes? Why did the albumin drop? Why did the INR rise? So these are the questions, and the most importantly, should we have stented this patient on the first when we saw him? And now that we are seeing him on 16th with these lab parameters, do we proceed with surgery or do we stent him now? These are the questions that we'll try to answer in this very short video. A common misconception that we all must have had at some point in our lives is that bilirubin is produced in the liver, whereas more than 90% of bilirubin production happens in the spleen, where senescent RBCs are broken down, hemoglobin is broken down to hemoglobin, eventually unconjugated bilirubin produced as a result of this hemoglobin breakdown is carried via the splenic vein, portal vein to the liver. At the same time, blood carrying the nutrients and some toxins from the intestine is also carried by the portal vein to the liver. Portal vein carrying all this blood with unconjugated bilirubin from the spleen and the nutrients and toxins from the gut delivers this blood to the sinusoids, where detoxification of the blood happens. The purified blood reaches the central vein from where hepatic veins and IVC. At the same time, the nutrients derived from the portal venous blood and the unconjugated bilirubin from the spleen are taken up by these hepatocytes. The hepatocytes conjugate the bilirubin. The conjugated bilirubin enters these biliary canaliculi and are eventually drained into the bile ducts. Conjugated bilirubin enters the duodenum, and this is the enterohepatic circulation that we all know. Almost all the issues of obstructive jaundice can be explained if we understand the single concept that in the normal liver acinus, the pressure inside the biliary system, biliary canaliculi, is about 2 to 3 millimeters of mercury, which is lower than that of the hepatic sinusoids. So the portal vein carrying this blood, the unconjugated bilirubin enters the space of DISI and the hepatocytes, where it's conjugated, enters the biliary canaliculi and passes down to the biliary system. When there is an obstruction anywhere downstream, it causes a back pressure related changes. So the pressure rises to about 20 to 30 millimeters of mercury, which is higher than that of the sinusoids. So the hepatocytes are no longer able to pump in the conjugated bilirubin from here to the inside the biliary tree. Rather, the conjugated bilirubin starts accumulating in the hepatocytes. This is the most important point that we need to remember, that this conjugated bilirubin accumulating inside the hepatocytes is toxic to the hepatocytes. It damages the hepatocyte cell membrane because of its detergent-like action. It causes hepatocyte apoptosis, and this is the reason for the elevation of the liver enzymes. It causes hepatocyte mitochondrial injury, so that the hepatocytes cannot produce ATP for their own functions. It also activates the Kupffer cells, which are present in the sinusoids, releasing a lot of pro-inflammatory cytokines. Eventually, these hepatocytes are no longer able to function properly. They have a lot of functions. When they lose their synthetic function, they are not able to synthesize albumin. Serum albumin drops. They are eventually they are no longer able to conjugate the bilirubin. So the conjugation or the detoxification is also a function of the hepatocytes. So the when the hepatocytes lose their ability to conjugate the bilirubin, the glucuronidation function is lost. That's when the indirect bilirubin starts seeping into the central vein. That causes a rise of the indirect bilirubin in the serum. At the same time, because of this obstruction, because of the interrupted intrahepatic circulation, absence of bile in the intestines causes gut mucosal integrity issues, increased permeability, endotoxin spillover. There's a lot of endotoxins getting released into this mesenteric venous system, all carried by the portal vein to the liver. At the same time, just the presence of high levels of conjugated bilirubin in the circulation causes a lot of peripheral hemodynamic changes and renal hemodynamic changes, predisposing a patient for pre-renal AKI. When AKI eventually sets in, this is why it's called as hepatorenal syndrome. So, in summary, because of the obstruction, because of the back pressure, conjugated bilirubin accumulates in the hepatocytes, eventually spilling into the blood, causing jaundice that we know. But this accumulation of bilirubin in the hepatocytes causing hepatocyte dysfunction, hepatocytes losing their synthetic ability, hepatocytes losing their detoxifying or conjugating ability, along with a state of pro-inflammatory state, endotoxemia because of endotoxin spillover from the gut, and renal issues. All these put together, when we subject a patient at this stage to a Whipple's procedure, we may expect a very stormy post-op period. So that is why it is important to understand while deciding to place a stent or not. It is not the value of bilirubin. There is no absolute value of serum bilirubin that can be taken as a cutoff above which we need to stent and below which we can avoid stenting. It doesn't work that way. It's a clinical call taken looking at various parameters, the most important of which is to understand the degree of hepatocyte dysfunction. And how do we assess hepatocyte dysfunction? Serum albumin, indirect bilirubin, elevation of liver enzymes, a mild elevation of creatinine, meaning that overall the patient is in this state, and if operated at that state we can expect a very high post-operative complication rate. So in a retrospective study done in Pennsylvania, uh, patient it was found that when the bilirubin was more than 13, it was associated with a very high 90-day mortality rate. So when we look at the patients A and B, both of whom have exactly same bilirubin levels, but the patient A with a normal total count, normal AG ratio, INR is normal, RFTs are normal and excellent performance status, and if this patient can be subjected to surgery within the next 2 or 3 days, it is known not required to stent him. Whereas patient B, we can see, though has the same amount of bilirubin, has all the warning signs to show us that if this patient is subjected to a Whipple's now, we may burn our hands. So this is when the clinical call is made to stent this patient rather than to proceed with surgery immediately. Now, there was an obstruction here. We placed a stent, bile drained down, all is happy. This is all logic. This is a hilar lesion which cannot be stented through the duodenum, through the ERCP route, because this complete obstruction is a higher lesion location. And this is a type 3A hilar cholangiocarcinoma, so which is drained by a PTBD. The PTBD does not relieve the obstruction at all. It just drains the bile inside this dilated biliary tree. How does this PTBD decrease serum bilirubin? Question number one. Question number two. This patient has a right-sided lesion. So by logic, we expect the degree of obstruction to be higher here. And why did we place a PTBD here? Why not a PTBD here? So how to decide this? Again, both of which can be answered by the very simple understanding of the pathophysiology of obstructive jaundice. everything is related to the accumulation of conjugated bilirubin in the hepatocytes because of increased pressure inside the biliary system. So that is the exact mechanism by which PTBD functions. It drains the bile and the same by which it decreases the pressure inside the biliary tree. So once this pressure inside the biliary tree is relieved, the bilirubin starts entering the biliary low pressure biliary tract. The hepatocytes start resuming their functions. They start pumping in the bilirubin into the biliary tract and eventually to the PTPD bag rather than leakage into the systemic circulation causing jaundice. That is why the serum bilirubin starts falling, and it prevents further hepatocyte injury in this drained system, and it allows the hepatocytes to resume function. Now, the most important point is for a type 3A hilar cholangiocancer, the treatment is an extrahepatic biliary tract excision with a right hepatectomy because this is the diseased biliary tree. Eventually, we will be suturing this left bile duct to the jejunum in the left head J. So, this lobe of the liver is the one that is going to be retained in the body. So, if we had placed a right PTBD first and drained this, remember that it is not just about drainage of the bile, it is about relieving the back pressure in the biliary tree so that the hepatocytes start functioning. That's the most important concept to remember. So if we had placed a right PTBD for this, the right sided biliary system is relieved of pressure. The right sided hepatocytes start resuming their function, whereas the left sided hepatocytes are going to continue in this vicious cycle, losing their ability. And eventually, when we do a right hepatectomy, we are going to be removing the functioning liver and leaving behind the dysfunctional liver. So this is why it's a very simple concept once you understand this. So for a type 3A, that is disease extension to the right-sided second order ducts, we do a left-sided PTBD followed by a right hepatectomy and extrahepatic biliary tract excision followed by a left hepaticojejunostomy. And the opposite is true for a 3B lesion. A right PTBD, left hepatectomy and EHBTE, right head J.